everybody. Good morning. Thanks for coming first thing in the morning to hear our talk. We are here to present the results of the PAASIM study. This is the first big reveal of the study results, and so we're presenting the results here today. And then we'll also be presenting them at the TropMed meeting in November. And we have a dissemination event planned in December in Beira, where the study took place. And then in Maputo, we'll be having a session to present the results to stakeholders in early 2025. So you get to hear it first. Oh, it's not working. Try again. Oh, there we go. Okay, so PAASIM stands for, and Drew's going to correct my Portuguese, but Pesquisa sobre o Acesso à Água e à Saúde Infantil em Mozambique. So research on access to water and children's health in Mozambique. So our agenda for the side session today. First, I'm going to be giving an overview of the PAASIM study to explain the study design, etc. And then Courtney is going to be talking about the impact of the intervention on water quality and access. And then I will talk about the impact of the intervention on enteric pathogen infections in children. Courtney will come back to present the gut microbiome conditions results, and then we'll have a summary of the results. And Courtney and I were the only ones who are actually able to be here present in the room today, but of course, a study like this, everybody in this room knows. Oh, sorry, then we'll have open discussion. Everybody knows that studies like this take a huge team of people, and in particular, I want to call out Matt Freeman, who's online, who was co-PI, as well as Rasul Nella, who might be joining as well online. And the three of us were the co-PIs. Rasul is at the Instituto Nacional de Saude in Mozambique, the National Institute of Health. We also had collaborators, the World Bank, Aura IP, which is the water regulatory agency for Mozambique, and then FIPAG, which is the water utility. And in particular, I want to call out Magalhães Miguel Mangamela, who was the co-PI from the Water Regulatory Agency, Aura. And Magalhães is really the person who had the idea for this study and knew that this World Bank investment was coming to improve water supply in Mozambique, and proposed to Matt to do a robust evaluation of that to look at the health impacts. We also have co-investigators at University of Nevada, Reno, Josh Garn, here at UNC, Joe Brown, Georgia Tech, Kostas Konstantinidis, and at Emory, Tom Clausen and Lance Waller. We had financial support from NIAID and also from Aura to do some of the water quality testing. Oops. And data and sample collection were done by WeConsult and in country, as well as INS and CIOB, which is the Centro de Investigação Operacional de Beira. And in particular, João Manuel was our co-investigator at CIOB. And of course, we can't forget the study participants who are critical to the study. Okay, so now I'll give the overview of the study. So PAASIM was a matched control trial to test if and how improvements in water supply infrastructure impact water quality and access, acute enteric pathogen infections, gut microbiome, diarrhea, and growth faltering. And we'll be presenting results on all of this today except for growth faltering. So why do we need a study like this? Robust studies of the health impacts of community water supply are needed because despite these, sorry, it's very hard to
it's hard
look.
to read out.
Stand over here. Despite our, we know these clear linkages between provision of clean water and improvements in child health. There's limited information that exists about the health impacts of these large water infrastructure improvements in low-income settings. So from Jennifer Wolf et al.'s study, systematic review of the literature on interventions, on wash interventions, there's really very limited data on improvements to source water. There's about 5 studies that assessed urban piped water impacts on diarrhea, and all of these in one way or another were more limited in scope compared to this study. So that said, with 5 studies, but billions of dollars are being spent annually to improve urban water supply. And so we really need rigorous evaluations of these improvements to guide policy and investment. So the other thing that is important and increasing in the field is that we need objective measures of infection and exposure to pathogens to understand the effectiveness and impact of water supply improvements. And this is really particularly important in urban areas because I'm sure you all have heard, but the global population is becoming much more urbanized. The majority of the global population is expected to live in urban areas by 2050. And that in particular is happening in Asia and Africa. And so the other thing that's happening, as we all know, is the effects of climate change. And these effects are particularly felt in urbanized populations. So this is a summary of the studies in the Wolf Review, and we can see that the majority are point of use interventions, not community scale interventions. The majority are in rural areas, not in urban areas. And so we have this limited data on community level interventions in urban settings. And here, it says 6 here, but it's really 5/6 because one of them was in 2 different locations. And so that brings us to this, project. So the idea of this investment by the World Bank, it's called WASIS-2, Water Services and Institutional Support, was to increase water access in urban areas of Mozambique. And it was a $200 million investment to improve piped water supply for people in 5 urban areas. And we focused just on one of those locations, Beta. And in Beta, and actually, well, yeah, in Beta in particular, this included, the improvements included rehabilitation of water treatment facilities, replacing existing pipe mains that were failing, emergency response repair of water supply systems, institutional support for local water utilities, improving service in areas with poor coverage and or low water pressure, and reticulation of water to supply to new areas. So this is, this intervention is affecting the whole city, and we'll talk a little bit later about how that's difficult to study an intervention that's occurring citywide. So in particular, like what we focused on for this study, there's also some at least planned subsidies of water connection fees for the poor. So what we were able to study in this particular trial was the improvement of service in areas with poor coverage and low water pressure. And so this was work to reduce water loss and in the areas. And so in some of the informal settlement areas. And so I just want to point out that these things are happening across the whole city, so they might have affected both intervention and control areas, but in the improving service in the areas with poor coverage, that really, we were able to look at both intervention and control areas. So what was the intervention? So this is an infrastructure intervention where they created new distribution system water network pipe replacements. And they removed illegal connections and what they called spaghetti lines, spaghetti tertiary networks where people had just kind of connected willy-nilly. And then larger tertiary network pipes were installed to connect the household to the secondary network within 25 meters. And household water meters were replaced to help account for water losses. And then FEPAG did a lot of promotion of new connections once the target areas were connected. So this is a map of Beta, and you can see this is the whole city of Beta, and we really focused in here on more of like the downtown urban area, and in particular in the informal settlements. And so these gray shaded areas are the locations, the neighborhoods that were enrolled in the study were in these areas. And the blue lines here indicate different parts of the water network. And the red lines are the new distribution system water network, so the pipes that were replaced. And then how did we find controls? We did a rapid survey right before we initiated the study to match at a sub-neighborhood level. And so we ended up with 36 intervention and 26 comparison sub-neighborhoods. Again, that's based on the data from our rapid survey prior to enrollment. And we matched on household density based on satellite images and random grid sampling, as well as poverty as defined by a Mozambique-specific simple poverty scorecard. Okay, so the study design. First, I want to walk you through our theory of change. So the idea of the theory of change is that if you change the drinking water supply, that can affect drinking water exposure, which can then affect gastrointestinal conditions in kids, and that leads to downstream health impacts. And so when we set out to do this study, one of the biggest things that we were looking to achieve was to update kind of a lot of studies that would take the upstream, like here in this case, drinking water supply intervention, and look at the downstream health impacts. And we really wanted to fill in some of those gaps in the middle, both about the environmental exposures and the internal biomarkers of exposure. And gastrointestinal conditions can be considered both internal biomarkers of exposure and also outcomes in their own right. So for drinking water supply, so first I'll walk you through the different household types. And so this is something that we need to sort of break down because it's a little complicated. So first we have the intervention neighborhoods, places that got improved water network. And so within those areas, not everybody is connected to the system. So you have households who are connected to the system in those neighborhoods and households that are not connected and do not have a direct water connection. People who don't have a direct water connection are getting their water from neighbors or from public standpipes, etc. Then you also have the unimproved neighborhoods. And within the unimproved neighborhoods, you can also be connected to the system and not connected to the system. So we end up with 4 different house types. And so these are our definitions at the bottom of what we call improved versus unimproved water network. Important to note is that this, what we do have, the comparison, well actually I'll get to that in a second. I'll hold that comment. Okay, so we have these different types of households connected to the system and within the neighborhoods. And then we're able to measure for drinking water exposure, drinking water characteristics at the network and then also at the household in both source and stored water. And then for gastrointestinal conditions, we looked at child enteric pathogen infection and also gut microbiome conditions. And then for health impact, we have diarrhea outcomes and growth outcomes. We also have mortality. Again, we won't be presenting today the growth outcomes because we have not done those analyses yet. So now we're getting to the analysis and what we're able to compare with these 4 different house types. So our primary analyses, and these were all predetermined and published in advance, and we have a protocol paper that we published. The primary analysis is comparing the houses in the intervention neighborhoods versus the control neighborhoods. And so this is where we are able to actually look at, this is the trial part, whereas the associations with direct household connections, which are comparing households 1 and 3 versus 2 and 4, these are subject to potential confounding, and so that we're calling those associations not impact. And so these are our primary analyses. We also have a bunch of secondary analyses that we're able to do and comparisons we're able to make between all these different house types. And so we won't be presenting on those today, except with the exception of this maximum exposure difference, the household types 1 versus 4, those that have an improved network with a household water connection versus those in an unimproved neighborhoods that are not connected to the network. And for those of you who like to read equations, this is our modeling approach. We use log binomial models for binary outcomes and multivariate linear regression for continuous outcomes, and controlled for clustering with generalized estimating equations. I will say that for the association with direct household connection, we controlled for whether people were in the neighborhood with intervention or not. So the data that we collected, this was a matched control cohort study. So we recruited moms at the end of their pregnancy and followed the kids through 12 months of age. So first, when the moms were pregnant, we assessed eligibility and consented the moms to participate. And then we followed up with surveys where we were looking at questions about the household, about the mother, about the child, and about the drinking water. And then we also took samples of source and stored drinking water samples and looked at indicator bacteria, turbidity, chlorine, and flow rate. We also did anthropometry measurements on the kids and collected stool samples from the kids to look at parasitology, gut microbiome, and enteropathogens. And we also collected dried blood spots, and that analysis is also in progress to look at serological response, so we could look at prior exposure to enteropathogens as well as other pathogens. And then we also had routine active surveillance with questions about the mother and child health. So what this looks like, this is, we had the recruitment visit, and then we followed from there with visits and to the child. The recruitment visit, then at the baseline visit, we started collecting household samples about household conditions, and then at each of the follow-up visits, we collected these different types of samples from the kids. And the data that we're presenting primarily is from this end-line visit, so the conditions of the children at 12 months. So this is our protocol paper. You can find it online, and we also have our pre-analysis plan published on OSF. So the study timeline, we started in 2018 when we found out that we got the grant from NIH, and we got to celebrate before we had to get to work. So then, unfortunately, we were getting ready to do this study. We had all of our human subjects approvals, etc., and a really terrible cyclone hit, basically a direct hit on our study site of the city of Beira. And this was very devastating for the city, and that basically slowed us down for a year on the study. Then we were getting ready and getting up and running again to get going, and you all know how this ends. We did our survey so we could do our matching, and then of course the COVID pandemic hit, and so that slowed us down for a year. And I just want to pause for a moment and say, you know, we all suffered a lot from COVID pandemic, and in particular in this study we wanted to honor Mario Mungoy, who was our field coordinator, who actually passed away from COVID during the study. So we felt, the whole team felt this on a very deep level. So then we got to around the end of 2020, and we were all sheltering in place, and our collaborator in Mozambique, Rasul Nala, said, we got to get this thing going, and we really have to start the study. And so thanks to her, we said, okay, let's do it. And we did our population-based survey at the end of 2020. And then finally, in February of 2021, we started recruiting and hitting the ground and started enrolling the pregnant woman. We did our follow-up visits through October 2023. Well, actually, the very beginning of November, collected our last sample. November 3rd, had all of our samples collected. One thing we wanted to highlight in this study is we really tried to do a lot of tech transfer and training of local staff and outfitting of local labs. So we did a lot of training and outfitting of the local water lab in Beta on both microbial and physiochemical parameters. We did training of the local parasitology lab personnel, and they were doing all of the parasitology testing. And then most recently, the CDC, in collaboration with CDC, we did a training on serology analysis for the dry blood spot samples, and that work is currently going on. We're getting those analyzed. So for data collection, here's a map of Beta showing our study participants. We enrolled 898 pregnant women, and that was equally split between intervention and control areas. And then we had a pretty large loss to follow-up, which is what we expected because this population is very mobile. These are some of the reasons that people that we lost to follow-up. The majority were those that moved out of the study area. And in total, we completed 642. Those were the completed means the people who went all the way through to the 12-month visit. And our target was 548, so we met our targets for our sample sizes. And that was roughly evenly split between the intervention and control arms, or comparison arms. So in total, we did about 3,600 household visits, and you can see this loss to follow-up as we go through to the end sample size of 642. So these are the study population characteristics at enrollment. We had several pre-specified covariates: poverty, sanitation access, secondary education of primary caregiver, and sex of the child. And for the most part, we had pretty good balance. Over here is the intervention versus comparison neighborhoods, and the one thing that was imbalanced there was how long people had been living in the study area. And then these are the direct connections, comparing those with and without the direct connection. There was a difference in the fixed employment for the primary wage earner in the household, which is not surprising given that you had to pay for a direct connection. And then any flooding in the household was also associated with a direct connection, which again is probably indicative, it's not too surprising, it's probably indicative of some sort of engineering constraints on the connections. Okay, so that's your big picture overview of the study, and now Courtney Victor is going to present the first results on the water quality and access. And I just want to just acknowledge Courtney, who is a PhD student at Emory and really ran all of these analyses that we're seeing today and led those analyses. And she's going to leave here after this presentation and drive back to Atlanta and defend her dissertation tomorrow. So, very impressive.
Thank you. All right, let's see some results. It's hard to see over here. Let me know if you can't hear me. So as Karen mentioned on our theory of change, we really wanted to get at those middle pieces. So did the intervention do what it was intended to do and reduce exposures through this drinking water pathway? So we explicitly included this analysis of the impact of the intervention on water quality and access to answer that question. So these are the metrics that we used as outcome variables in this analysis. Everything shaded in blue was measured with IDEX in this case, and everything else was self-report on those household surveys. Household source drinking water quality at 12 months was our primary outcome, and we defined that by prevalence of any detectable E. coli in a 100 milliliter source water sample. We also looked at primary drinking water source, which was the definition of the basic service level definition from the JMP. We looked at household source and stored drinking water quality using the same definition of any E. coli detectable in source or stored water sample across all time points. Water access was defined by prevalence of a water source that was accessible on the premises. Water availability, all these other ones below were satisfaction. Water availability was access to sufficient quantities of drinking water when needed. Water insecurity was defined by an H-wise index score of greater than 12. or 12 or more. Water consumption was liters of water consumed per day, categorized by above or below the median usage of all our study participants. And then we asked questions about user satisfaction with water service, affordability, availability, pressure, appearance, and smell, which we think is a unique data set to include here. So we're going to see this, there's a lot of data and a lot of results. We have a lot of outcomes, so we came up with this schematic to hopefully ease the burden on your eyes when you're looking at our giant tables. So on top, it's hard to see that it's like a light green. If it's shaded like that, it means it favors the intervention or favors direct connection. If it's shaded in white or no shading at all, we observed no effect. And shaded in this purple color is favors comparison or favors no direct connection, so sort of the opposite of our hypothesis. And then we shaded a little bit darker if we see a strong association or impact of the intervention. So our first question, as the fidelity of the intervention, this wasn't an explicit outcome, but we wanted to look at, did the intervention impact or increase direct household connections? And we see that it did. So we broke this out across all time points and then at 12 months, because that was our primary outcome. And we see that living in an intervention neighborhood led to an increase in direct connection across all time points at the end of follow-up. So kind of showing that the intervention did what Karen mentioned when she was showing what their priorities were. One of them was increasing connections, and so it did do that. So this is just descriptive data on E. coli contamination in source water at the end of follow-up, which is our primary outcome data. This graph here is showing the prevalence of the frequency of detection in all of our samples categorized by these WHO risk categories for E. coli contamination in source water. And we show these here to point out that overall, the source water is pretty clean. This is the less than 1 mpn per 100 mil across both intervention and control. We do see maybe a pattern of, at the higher risk levels, it was higher in control across the board, but overall very clean when we look at this in intervention versus control and among those who had a household connection and those who did not. So our first question, our primary question, was did the intervention impact E. coli in source and or stored water at the end of follow-up? Source water was our primary outcome, but we're also presenting the stored water results here because we think it's interesting. And we do see that the intervention led to a reduction in E. coli in source water by about 33% at this 12-month visit, and see a reduction, though not as precise or as great of a magnitude, of E. coli in source water or stored water at the end of follow-up as a result of the intervention. We do not see the same pattern of effect or same magnitude of effect associated with having a direct household connection. We do observe a reduction, though imprecise, of E. coli in source water associated with having a direct connection at the household. We do not see an impact and, in fact, observe a slightly higher risk of having E. coli in stored water associated with having a direct household connection, though this was also an imprecise estimate. I just wanted to quickly say, when I mentioned source water, I'm discussing when we went to a household, this is where we took a sample from where they were getting, what was the source of their water, and then we took stored water samples from wherever they were storing water, and 99% of the participants in our study stored water, so we were able to get most of those. So this is a lot to look at, one of those big tables, and I do have forest plots after this for those of you who are more visual, so you can avert your eyes for now. But this is all of our outcomes across all time points, so now we're not just looking at the end of follow-up. And we do see that the intervention led to a reduction in E. coli in source and stored water across all time points. We see an interesting sort of opposite effect of our hypothesis of an increase in water insecurity from the in those who are in intervention households, though this is an imprecise estimate. And then we see increase in access to basic water, water availability on the premises, and satisfaction with water services associated or as a result of the intervention. So here's the forest plot I was talking about. So we broke this up in two ways here because for these three variables, a lower risk ratio favors the intervention. We wanted to highlight that. And then everything below this dotted line, a higher risk ratio favors the intervention. So we just wanted to delineate that. And you can see on the whole that the direction of effect follows our hypotheses. We see lower contamination of water quality and greater access and satisfaction with services taken together. So the intervention led to improved water quality, access, and satisfaction across all time points. So our second question was there an association between having a direct household connection and water quality and access controlling for the intervention level? And similar to the just at 12-month time point, we do see a slight reduction of E. coli and source water across all time points associated with having a direct connection. We see no effect on reduction of E. coli in stored water. And we see higher water insecurity among households who have a water connection compared to households who don't, associated with that. And we see, similar to the impact of the intervention, an increase in access to basic water, obviously an increase in water available on the premises, because that by definition is a direct connection at the household, and increase in satisfaction with water service, affordability, pressure, and also an increase in water consumption. So if you had a direct connection, you were more likely to report consuming more water per day, which makes sense. So direct connection was associated with improved access, satisfaction, and increased consumption. And as Karen mentioned at the beginning, we also wanted to look at this maximum exposure effect. So looking at households in one here, saying is there an additional different impact or greater magnitude of effect for households that were both in intervention neighborhoods and had a household connection. And we did see that on the whole, it might be a little hard to follow, but these orange point estimates are intervention and the household connection. And you see, it's going to be hard to do this here. I apologize to the folks who are online and can't see my laser pointer. But you see a greater magnitude of effect. Oh, there we go. Where these red arrows are, there's a greater magnitude of effect when you have both intervention neighborhood and a household connection across these variables here. So the combination of having both living in the intervention neighborhoods and having a direct connection led to increased magnitude of effect, protective effect against E. coli and source water, and increased satisfaction and availability. So our key takeaways, the intervention led to a 33% reduction of E. coli and source water at the end of follow-up, which is our primary outcome, and a 26% reduction throughout the study. The intervention led to a 14% of reduction of E. coli and stored water throughout the study, but looking at just the end of follow-up, we didn't see as strong of a reduction. There was an increased access to basic water and water on the premises, and increased satisfaction with water service, affordability, and availability. And having a household connection was associated with minor reductions of E. coli in source water and no reduction of E. coli in stored water across all time points. But we did observe having a household connection was associated with increased access to basic water and water consumption, increased satisfaction with service, affordability, and pressure, increased water insecurity, interestingly. And then living in intervention neighborhoods and having a household connection resulted in this overall trend towards improved water quality and access that was a greater magnitude of effect than just the intervention alone. So I'll stop there, hand it back over to Karen, and I think we're going to do questions at the end. I don't know if we said that at the beginning.
We're going to say that. Thanks.
Where's my water? Oh, thank you.
Okay, so now we're moving on to did the results that Courtney showed have an effect on the enteric pathogen infections in children, and as well as diarrhea. So our primary outcomes were prevalence of any bacterial or protozoan pathogen, prevalence of any bacterial pathogen, prevalence of any protozoan pathogen, and then the prevalence of any co-infection. And I just want to point out that we left viruses off of the first three because we felt this in our pre-analysis plan. We thought that viruses were less likely to be associated with the water system. We also, when we decided that we tested for DAEC and EAEC, diffuse adherent E. coli and enterooperative E. coli, we decided there was insufficient evidence of those as pathogens, and so we left those off of our counts for prevalence of any bacterial pathogen. We did look at them individually, however. And then secondary outcomes were prevalence of any viral pathogen, prevalence of any helminth, diarrhea, pathogen count, and prevalence of individual pathogens. The way we tested for these was using the TACMAN array card assay that simultaneously can detect we had 48 targets that looked at 26 enteric pathogens, 11 AMR genes, and I'll note that this work was done in Joe Brown's lab here at UNC, and I really want to give a shout out to Aaron Kowalski, who did all of the lab work, as well as many other people in the Brown lab who contributed to the lab work as well. So just to remind you again, this is just for the 12-month samples. That was our inline analysis. And we have not run we have samples from the other time points, but we have not run them. So first, just looking at what was the prevalence of infection in this population. Overall, we had pretty high prevalence. So any bacterial or protozoan pathogen, we had 84% of these 12-month-old kids who were infected. And co-infected, we had 61% of kids who were co-infected. So pretty high force of transmission in this population. So our first question, did the intervention impact pathogen infection with our primary outcomes? So we did not see any effect on the primary outcomes. Pretty close to 1.0 results with large confidence intervals. So then looking at the secondary outcomes, we did find that the intervention led to a reduction in pathogen count per child, and then we did not have enough data to look at helminths. Diarrhea was not affected, or was slight trend, but really large confidence intervals as well. Same with the viruses. Then we looked at individual bacterial pathogen infections, and we found that there was some trend towards a limited effect on the bacterial pathogens. Everything was kind of slightly protective, with exception of DAEC, but most of those measures were pretty imprecise, with the exception of enteroaggregative E. coli, for which we saw a stronger protective effect of the intervention. And again, for you visual, I guess,
It'll be after.
Okay, afterwards. We'll show all the tables first. Okay, so viral pathogen infections. Interestingly, we saw a little bit stronger point estimates, but again, imprecise estimates for viruses. And then for protozoa, we wanted to highlight this result for Cryptosporidium, even though it was an imprecise estimate. We are pretty intrigued by this because Yarrow Linden in Joe Brown's lab did some large volume sampling in the system, and we're not presenting those results today, but in her large volume sampling of the system, we saw Cryptosporidium across all different sample types. So we saw in standpipes and in household samples, source water samples, we were detecting Cryptosporidium, suggesting that that it was in the system. And even though the E. coli counts were pretty low and chlorine levels were decent, there's probably some they were probably missing some filtration steps. For helminths, we just didn't have enough data for the models to run, just showing for completeness sake. So here's our forest plot. So we see, as you can see, pretty large confidence intervals here, but point estimates that were generally protective. And for EAEC, we did see that that was a stronger effect. So then now we're moving to looking at direct household connections. So that what I just showed you was whether people were in the intervention area or not, and now were they connected to the system. For our primary outcomes, we did not see any evidence of association. For the secondary outcomes, again, pretty limited associations. And the pathogen count was not significant for the direct connections as it was for the intervention. And then for specific bacterial infections, interestingly, the effect kind of went in the opposite direction. It was, again, wide confidence intervals, but everything kind of trended in the other way. So this was for viral infections. Really surprisingly, norovirus with a direct household connection. This is not something that we expected, but that seemed protective. And then for protozoan infections, the cryptosporidium protective effect, or slight protective effect, went away. And then helminths, again, we couldn't run. And then, I just wanted to, we also did kind of we wanted to try out this analysis of using community ecology techniques to look at the communities of pathogens that the kids were infected with. So comparing the whole sort of set of all of the pathogens we tested. And so if this is not, these are not our results, just to be clear, this is an example of what it would look like if you had separation and you saw very different communities with like an intervention versus a control. This is what it would look like. This is not what our results look like. So here we have the results for comparing intervention versus control and comparing the direct connection versus no direct connection. So we're not seeing differences in communities, which is not too surprising. But I do think that this is a cool way of looking at these kind of data that we can be using in studies. And I think, you know, if you were looking at different ages, you might see something very different. We're working on that in some other studies. So here again is the interaction models, the results of the interaction models looking at both that maximum contrast of the intervention alone versus the intervention with the direct household connections. And again, for several of the outcomes, we see that the effect gets a bit stronger when you look at both with the directed, both the intervention plus the direct connection. So the combination led to increased magnitude of effect for some of these outcomes. And again, for the specific pathogens, for several of these, the effect got a bit stronger. Still not, still pretty large confidence intervals. So the combination did lead to some increased magnitude of effect. So our key takeaways from the enteric pathogen work: first, the impact of the intervention. There was no impact on individual primary outcomes, although there was some evidence of a weak protective trend overall. There's some limited evidence of protective effect on co-infection and pathogen count, some effect on individual pathogens, in particular for EAEC, and this evidence of weak protective trend across most of the pathogens. And then when we get to the direct household connection, we do not see evidence of association with the direct household connection, and in fact that weak trend goes in the opposite direction. That said, living in the intervention neighborhoods and having the household connection did increase the strength of the effect in many cases. So now we get to see the results of microbiome.
All right. So, yes, we're going to look now at the impact of the intervention on gut microbiome composition at 12 months of age. As Karen mentioned, this is kind of an internal biomarker of exposure, and we think this is a unique and novel outcome / marker of exposure to look at. It gets a little complicated because it is the outcome here, but we're using it, its utility is more as a marker of exposure. So the data we got for this analysis was from 16S rRNA amplicon gene sequencing from the 12-month samples only. I have so far in here because we do have 3, 6, and 9 gut microbiome data from a subset of our samples that we recently got a couple weeks ago, so that will be added to this analysis in the future. And a shout out to Janet, Anna, and Kostas in the Constantinides lab at Georgia Tech for processing and sequencing. They coordinated with Aaron, again, to get all these samples, sequenced the data, and gave us some good data. So our analytical approach, I don't have enough time here to go over all the nuance and complex questions that we had with the microbiome data, so I'm happy to answer questions after if you have any. We looked at alpha diversity, which is a measure of within sample diversity for each kid, using Shannon's diversity index, which measures the evenness and richness of bacterial species or taxa in the gut. And we modeled this using multivariate linear regression models. We also looked at beta diversity, which is comparing whole community composition, similar to what Karen was just talking about with pathogen communities, but bacterial communities, comparing between kids. And we measured beta diversity in 2 different ways, using weighted unifrac distance, which tells us something about differences in relatively abundant and common taxa in the gut, and unweighted unifrac distance, which tells us about differences in rare taxa that might be present or absent in the gut. We cannot model this in the same way because we were comparing whole communities and matrices. So we used Adonis 2 models to do Permanova significance testing, running the same kind of model structure with our imbalanced covariates, our pre-specified covariates, and the exposure. And then we also tested for differentially abundant genera here using the Maslin 2 package, which employs log linear models to test for individual differential abundance of genera in the gut. And we controlled for false discovery rate by collecting the p-values and had a q-value significance threshold of 0.25. Oh, this should have been deleted from here. Here's more details on that. So the impact of the intervention on alpha diversity. You'll note these tables are not shaded because even if we do see differences, we don't actually really know what that means globally. I think generally people associate higher diversity with health. But specifically in this population where we don't have a lot of data, and in children, I don't think we can make that broad of a claim. So nothing is shaded here. So we'll just talk you through. We don't see a significant association or impact of the intervention on overall within child diversity, though we do observe a slight decrease in alpha diversity associated with having, or as a result of the intervention. We also don't see a difference in beta diversity defined by weighted unifrac distance, which tells us about common taxa. You see this unadjusted NNDS plot on the right here. On the left are the adjusted model results, and we don't see a significant difference in community composition as a result of the intervention, or with unweighted unifrac distance, which tells us about rare taxa. So similarly, we don't see the separation by the intervention or a result from our adjusted models that says the intervention was led to differences in beta diversity. We also just tested the difference in average community dissimilarity within groups to between groups, and it's a little confusing, so I'll try my best to walk you through it. But the box plot all the way on the left here is the between groups, so we're comparing every kid to every other kid. Comparison group and intervention group are both, we take the average dissimilarity within those groups, so we're only comparing kids within comparison groups to other kids within comparison groups and measuring the average dissimilarity, similar with intervention. And on average, we don't see that there's a difference in overall community dissimilarity when you're comparing kids within the same group to between groups. And we found no differentially abundant taxa associated or as a result of the intervention. So now we're talking about the association between having a direct household connection and alpha diversity. Again, we see no association, though we do observe an opposite direction of effect with a slight increase in alpha diversity associated with having a household connection. We do see modest differences in community composition defined by weighted unifrac distance here, where you can start to see some of that separation by community structure, and our adjusted models did suggest that there's significant differences in common taxa and the abundance and presence of common taxa as a result associated with having a household connection. And similarly to unweighted unifrac distance, again, these don't really pass the eye test on the left, but these are our unadjusted, this is an unadjusted plot of the community composition, but the adjusted Permanova results suggest that there is differences in rare taxa, the presence or absence of rare taxa in the gut associated with having a household connection. Here we similarly see that the between group dissimilarity is higher than the within group dissimilarity, so that if you're comparing all the kids within their group, the average dissimilarity between kids is lower than when you're comparing across intervention groups. And we did find a significant depletion of genus Prevotella 9 associated with having a household connection. So these are the results from those models. And we did not observe this combination maximum exposure effect had a difference on alpha or beta diversity, but we did observe reduction or depletion of 2 different genera, Prevotella 9 and Catanibacterium, associated with or as a result of living in an intervention neighborhood and having a household connection compared to kids who lived in comparison neighborhoods without a household connection. So key takeaways here. The intervention did not lead to any major changes in the gut microbiome diversity or composition, though having a household connection was associated with changes not in diversity but total community composition or beta diversity and depleted Prevotella 9. And children who lived in intervention neighborhoods with a direct connection had depleted Prevotella 9 and Catanibacterium. And I will hand it back over to Karen for a summary.
Okay, that was a lot of results, we know. So now I'm here to try and make sense of it all. So again, we presented results on all of these different parts except for the growth faltering, which is forthcoming. And so our summary, I'm just going to go through each of these questions again and remind us of the results. So first, did the intervention lead to more connections? Yes. We saw about 34% more contracted connections to the water system at our final visit. That said, it was still only 41% of the people in the intervention areas that had direct connections. So not everybody had connections. Did the interventions improve water quality and access? Yes. We saw lower water contamination in the intervention areas, although that was not observed for the direct connections. We saw higher reported water access, and that was also observed for the direct connections. Greater satisfaction with water services, which was also observed for the direct connections. The effects were generally stronger for the combination of the intervention and the direct connection. So, and we think this is the first study that we're aware of that is examining these outcomes for an urban water supply infrastructure improvement project with health outcomes to look at all these exposure measurements. And so the investment did successfully deliver connections and improve water quality and access. And likely the stored water, due to the lack of continuous supply, hindered the effectiveness of the intervention. So future research is needed on the sustainability of the network and mitigation of these unsafe water storage practices. Did the intervention, did that translate into an impact on child enteropathogen infections and health? We would say there's some limited evidence of the impact of the intervention, but no evidence of association with the direct connection. So there's no impact on these primary outcomes, the prevalence of any bacterial or protozoan pathogen or diarrhea. There's some evidence of the impact on prevalence of co-infection and pathogen count. There was this consistent weekly protective trend across enteropathogen measures that favored the intervention. No evidence of the association with direct household connections, although there was a strengthened effect when we looked at the combination of the two. And then we, as I mentioned, we thought that the evidence on the cryptosporidium was interesting given the detections within the water system of cryptosporidium, which is also, I failed to say it earlier, very important. If kids get infected early with cryptosporidium, that can lead to long-term effects on growth, etc. For the gut microbiome, we saw no substantial impact of the intervention. It didn't substantially impact diversity or composition. There was some limited evidence that the combination of the intervention and direct connection led to depletion of potentially harmful taxa. And we should just note that this 12 months time point is a transitional period, and adding that longitudinal data will potentially provide more insight. So here's our summary slide of the impact of the intervention, and just to remind you that this is our key with the purplish color favoring the comparison. Darker means it's more strong connection, no direction of effect in white, and then the green over here for favoring the intervention. So for water supply, we did see this impact for direct connections. Water that also translated into water exposure. That it did not, it only weakly or did not translate into differences for the gastrointestinal conditions, and did not so far yield any differences in health impacts. And then if we layer on the direct connections on top of that, just to show you on the key, it's sort of like over here on the right, we added in a little bit of how that how that changes. For the most part, it was similar between the intervention and the direct household connections, but in some cases there was no effect for that household connection where there was for the intervention, and then in this case it went kind of in the opposite direction for a weak trend. So what are some of the explanations for these findings? First, the summary of this water system improvements did impact the water access and quality, but that did not substantially translate into downstream impacts on what we're detecting in the children, possibly because of a variety of factors related to water conditions. First, it just was insufficient impact. We didn't move the needle enough on the water system. Possibly also related to the fact that there was like overall low water contamination in the source water. So it was not a highly contaminated water source in the intervention or the comparison areas. But also these improvements didn't lead to 24/7 continuous water supply. And of course, we all know that that means that people store their water, and that water storage may negate the effects of the improved water. And again, not everyone had that direct connection, so the effects were biased toward the null, although those interaction models did try to get at that. Related to microbial conditions, this is just a very high pathogen burden population, right? So there's a lot of transmission happening, and many other sources of these pathogens are out there in the environment and can lead to infection. And then also similarly for the microbiome composition, there's a lot of other things that can influence microbiome composition that can be important determinants. I really wanted to highlight some of the challenges of this study because this was a really hard study to do. So first of all, this was a natural experiment. We had no control over the intervention. And so, we weren't able to randomize the intervention. So it's a quasi-experimental study. And understanding the intervention was a huge challenge to know what they were actually doing on the ground. And knowing about the rollout and the timing of the intervention was a big challenge. And so then we needed to know when was the appropriate baseline period, because this was something that was being done sort of rolling out continuously and changing over time. And so it was very hard to know what that baseline period was. Really interestingly, after Cyclone Idai happened in Beta in 2019, it was a horrible event for the city, really destructive, but that also led to a lot of money pouring in to Beta for improvements. And what ended up happening is that they were able to use those funds that were rolling in to increase the amount of coverage of these improvements. And so that was really good for the city of Beta and the people of Beta, not so good for epidemiological study design because some of our control locations turned into intervention areas. So we had less control neighborhoods than we had anticipated. And again, we were not able to examine the impacts of all of these aspects of the citywide improvement. So we focused on this tertiary system and promotion of the additional connections because that's where we were able to get a robust counterfactual. But some of these improvements were occurring upstream of those tertiary improvements, and so affected both intervention and control neighborhoods. And so this contrast is not system versus no system. It's this particular aspect of the upgrades to the system. And so this finding, this valid counterfactual, was really challenging in this citywide community-based study. One thing we found when we went is that when you go and we're like, oh, we'll look at changes when they bring the water system but then you realize that that is gentrification. So like if you bring a water system to a neighborhood, new people are going to move in there and they're going to be very different than the people who lived there beforehand, or maybe nobody lived there beforehand because there was no water. So there's no appropriate counterfactual there. So that's part of why we focused on this, the particular area that we focused on. And then of course we had challenges that were common to all of our studies. I'm sure you all have experienced these: supply chain issues, the natural disaster, similar to political unrest or whatever major event happens in many sites all over the world. Everybody experienced the issues with COVID, and also we only had so much time for our follow-up period. Although in the case of this study, we saw this a bit as a strength because following the kids only for that 12-month period protected us from some longer term trends that might have affected kids if we had followed them up for longer periods of time. So we thought actually keeping it short was a bit of an advantage. We also this study had a lot of strengths as well, and I think one of the biggest ones is just that we did it at all. Because as we showed you before, there's just not that many studies, and this is kind of the first study of its kind. There's, we can quibble about like the particularities of other studies that have been done, but it's the first study of an infrastructure improvement project in sub-Saharan Africa, and using some of the outcomes that we used. And just because it's hard to do does not mean we shouldn't be doing these kinds of studies, because this is where the population is moving. This is, urban populations, and understand these investments are happening, and it's really important to know, to be able to study them as best we can to get more information about their impact. It was complicated, but it was kind of ended up being pretty interesting that we were able to look at both these like neighborhood and household level effects of the direct connection versus the intervention area. We do think that we ended up with a robust counterfactual, especially given those challenges that we were facing. We measured exposure, and we did that both through these environmental, external measurements of exposure, as well as the internal measures of exposure. We have a lot of cool outcome data for these novel objective outcome measures. We think that the results are relevant for policy discussions, and it was, I thought, particularly gratifying that we weren't the ones who came up with this question. This was, as I mentioned, Magalhães was the one who really came up with a question and wanted to look at the impact. And we tried our best to really maintain strong partnerships with academic partners, as well as regulators, policymakers, and the utilities throughout the project. So our future analyses that we have planned, we are going to be looking at growth faltering, as we've mentioned, mortality. We'll be able to look at prior enteropathogen infections once our serology data comes in probably in a couple months. And then we'll be looking at those prior points for the gut microbiome, as well as antimicrobial resistance, because we have all that from the TAC. We are also looking at different sort of associations between some of the different exposures and outcome measures, and Courtney presented on some of that yesterday. And then we'll have a treated analysis, and we're still in conversations to decide what counts as of the treated or treated. We will publish those pre-analysis plans before we get into it. In addition, we have several analyses that we'd love to do, but we don't currently have money for. So if anybody has a couple $1 million they want to give us. So we want to test those samples, those earlier samples of the 3, 6, and 9-month period to look at the enteric pathogen. That would be very cool to do, but we currently need some money to do it. We'd love to do metagenomic sequencing of the banked samples because right now we have 16S data only. And then it would be amazing to be able to do a follow-up study of the intervention and look at the long-term effects. So these are the papers that we've published to date on the study. If anybody wants to go look at them, and several more forthcoming. And that's it. Now we're ready for our open discussion. You can ask all of your burning questions, and if you run out of those, then we can, we have some questions that we can put up for discussion.
Back to the QR code, please, just
Yeah.
for a second. Thanks.
Yeah. And Matt Freeman is online and can answer questions in the chat and also chime in if we need him to. All right. Amy.
Amazing amount of work and really, really nice presentation. I really loved how you organized the presentation today. Yeah, you covered everything, so, but I do have questions. I was wondering if you could talk a little bit about characterizing the intermittent supply, and was it similar in treatment and control neighborhoods, and was it available for an hour per day or twice a day? I'm just super curious about that. And then also, if you could say a little bit about how the water was being treated and like the level, was there chlorination, residual, did you test for that? And was there a difference?
Can we take a stab at it? So for intermittency, we have data on intermittency. I think we have hours per day and days per week reported by the respondents. We have not looked into that yet. I do believe when I did some preliminary, just summary statistics, it was relatively high, but definitely not 24/7, like maybe 16 or 17 hours a day was the average reported. And then for chlorination, I got a similar question yesterday, and I don't know if this was a decision we made before because of the cyclone, but Karen mentioned as a result of the cyclone, there was a lot of additional investments for the whole city, and one of those was hyperchlorination of the system. And so I think that might have been at the time why we didn't include chlorination as an outcome for the water quality and exposure variables, because we thought that the whole city had received that, and that wasn't necessarily part of like we didn't have a good counterfactual, as Karen was mentioning, for that. We do have that data, and we could do some more probably to look at comparing intervention and control.
But it is pretty high.
Yes.
The chlorination seems to be decent in the system, and we have to look at it a little bit more carefully to answer that. But it is being chlorinated, and we think that's why we're seeing pretty low E. coli counts. But then, of course, the cryptosporidium is resistant to chlorine. So.
And the stored water was pretty high. I mentioned it very briefly, but at the end of follow-up, 99% of participants across all households were still storing water.
I have more questions, but I'll let other people.
So my question was just a quick follow-up on that then. So in the stored water as well, was there also still like maintaining a residual chlorine concentration?
We did not test that, did we? I don't have data on testing the stored water for chlorine
Okay.
that I'm aware of.
We'll get back to you on that.
Yeah.
Thank you.
That was really great, guys. And you really did answer a lot of my questions at the end. But I wanted to follow up with the intermittent supply. Does the utility have any information? Because it might be really interesting to see between the groups and see what kind of data you can pull. The other thing, what was I going to ask you about? Oh, shoot, now it's gone.
Actually, I'll just comment on the intermittency. One thing that we, Sydney Hubbard, who did her dissertation on these data outside of the intervention versus control, looked at seasonal effects and did see differences between seasons of the amount of the water supply, a number of hours per day. So when we presented those results to FEPAG, to the water utility, they said, yeah, That's because we're managing based on based on the rainfall. Like we're actually changing our delivery based on the challenges for the processing of the water. And so they weren't surprised at all to see that the number of hours was different seasonally. So we should have put that up as future analyses also, as looking at seasonal effects, because that's another thing we're going to be looking at.
Was the source water groundwater or surface water, or is there more than one source?
Surface water.
Surface water and not filtered?
Well, theoretically, it should be being
Or is
filtered.
it being filtered through like
Yeah.
a sand filter?
It's a full water treatment plant, and then they have booster stations where they're adding chlorine within the system. So again, that's another thing that's a little bit hard to know exactly what's happening upstream where. But they theoretically should have a filtration system. When we presented the results of the large volume sampling to the Water Regulatory Agency, they were very interested in following up with the utility about the filtration steps because of seeing the crypto.
But if they have low pressure events, you're maybe just getting
Right.
contamination.
Yeah.
I have one back here, and then I'm gonna,
Comment on the previous question, please.
This is from Matt Freeman online. He says that he does believe that they tested for chlorine in the stored
Yeah,
water.
Okay.
I think we
Is
did
it?
too, yeah.
Okay.
Sorry.
Q&A can resume. Thanks, Matt.
my question was around, so you have the cyclone, so there was a lot of wash infrastructure and maybe other wash related activities going on in the area beyond the water infrastructure. So I want to see, did you capture information on that? Was there hygiene promotion within these areas, both in your control and intervention areas? Other forms of interventions that were occurring during that period of time? People distributing chlorine tablets, for example. So do you have information on that?
So we don't have great information about that. We have some information about, we know that there were additional resources coming in, and certainly immediately after the cyclone, there was distribution of chlorine. There was concern about cholera outbreak at that time. And so there was a lot of activity then. That was in 2019, if you remember, March 2019, and we didn't start the study until 2 years later. So I think any of the major additional impacts of the cyclone, those sorts of programs were probably reducing over time. We did not, it's too hard to track what all the different NGOs are doing, especially in a situation like that. So we don't have good information, but other than, so in particular, the cyclone released funds that were dedicated to doing additional, expanding this water improvement project. So we know that. So that was more of an infrastructure thing. But yeah, I don't think that we have great information about sanitation investments or anything
I
like
was
that.
asked about that sanitation infrastructure as well.
Yeah.
Being on the ground, did you see that? Were there sanitation projects that were ongoing within your areas?
I think we have to, I don't feel confident in answering that question. Yeah, Matt, I don't know if you have anything else you want to say about that. Feel free to unmute and chime in if you have anything else.
Hi, great talk. I just have a really minor question. So I think you showed us the results that improved water was associated with high water insecurity. Could you tell us more about how you assess this water insecurity,
Yeah.
such as criteria for that?
Yeah, that's a great question. Thank you. So we used the HY's Water Insecurity Index, and it's a series of questions, and you sum it and get a composite score. And then there, we follow kind of their approach for categorizing. So a score of greater than or equal to 12 was deemed to be water insecure. And when we saw that finding, I did just nothing formal, just a preliminary look at each of the questions. And there was one question about, I think it was reliability of service or worry about reliability of service, that people in intervention neighborhoods were consistently reporting more often. And I think it was Karen and I discussed it, and Karen made the point that people, they weren't blinded to the intervention. So they knew they were supposed to be receiving upgraded water supply. And we think that maybe their expectations for water supply and service were higher. And so they were more likely to report being worried or disappointed with the level of service that they were getting. And maybe that's what's driving it. But it was that one question. And then for direct household connection, it wasn't one question, but across all of the questions, people who had a direct connection were more likely to report, I think, rarely than never. Whereas everyone who didn't have one were more likely to report never for a lot of the questions. So I think it's interesting. It might be, for the direct household connection especially, it might be related to, like, if you don't have a connection, then some of these questions might not be relevant to you. And so I think it's a really interesting finding, and we have some work to do because we have all these other questions about water access and satisfaction to kind of compare the answers to those questions to our other questions about water access. But yeah, thank you for bringing that up.
Yeah, also just a little bit more on that point is like people now are paying for their water. They might be more noticing a lot more if it's going out on them and more disappointed. So again, that expectations. So, and a lot of people had like illegal connections. They were just kind of plugging into the system beforehand, and now they actually had a water meter that feedback is coming by and checking on. So when you look at the World Bank documents on this, it's like what was the term? It was
Non-revenue.
The goal was to reduce the amount of non-revenue water. So it's interesting when you think about it from that perspective.
Hi, thanks. Great presentation. Following up on that, were you able to measure how long households were storing water for and how much water was being stored? Because I wonder if having access to piped water and that concern about access may have modified that behavior and then also modified how much stored water was being kept and then consumed in intervention households.
That's a good question.
Yeah.
I don't know if we know how long
or
directly how much. I think more than 90% had a jerry can that they were storing in. It wasn't like a infrastructure, something that they built, like a storage, something formal to store water, like a cistern. It was those, like that picture I showed, that was most often the case. It was jerry cans or buckets.
But you look at the number of jerry cans, number of liters that each household was storing and for how long. Okay.
I've tried to do that in other studies. It's hard to get, because you also don't know if something's full or not, so you have to go and check. And so it's that, I have tried that and with not great success to try to get at that question, and that we didn't have, it just wasn't a priority in terms of the time for our field workers.
Great job and congrats. This is so much work. I know you all have been through a lot with this study. I'm just curious, you mentioned obviously this is like a high burdened population with pathogens and other sorts of infections, and getting to know the context over the last 5+ years. What do you think are some other things that are driving these infections, and like kind of what should be the next steps, like post piped water?
That's a great question, and Courtney might also have thoughts. I think the question about what else was being done is really relevant. So, sanitation obviously is I would say a big one, and understanding what's coming into the system in terms of sanitation. Food, I think, is another one. We're getting much more interested in food as a pathway. There's many different pathways. There's also potential interactions with other infectious diseases because there's a lot of like dengue in this area. So those are just some of my thoughts. Plenty. These are very, informal settlements with a lot of opportunities for pathogen transmission. Courtney, thoughts?
We did have that variable on the enrollment table about observed basic sanitation access, and it was low. So I think that probably agree with everything Karen said, but just adding that context.
I got the Burma Nova. It's totally new and cool and interesting to me. I wanted to know what kind of variables do you adjust for? You mentioned adjusted. What kind of variables do you adjust for, and what did you adjust for, and what can you adjust for?
Yeah, in the Permanova testing? Yeah, so you can set it up like a traditional model, and it's a distance matrix as your outcome. So we used the same modeling approach that we used for all the other measures for those Permanova models and adjusted for our pre-specified covariates and the imbalanced covariates. Do you have something you want to say? Okay. In that model. And then pretty much you can put anything in it and look at how those different environmental variables, a lot of people will put in multiple variables and look at each of them. We were controlling for those variables, so I didn't look at their associations or impacts with the distance matrix, but that is something we can do. We were just interested in that primary exposure variable in those models. Anything to add to that? Okay.
I was wondering what the timing looked like for enrolling pregnant moms and like how much exposure they had to the intervention before they were enrolled, and like how tight your measurements were at 12 months, or if there was like a little bit of like buffer around that. And then
Judd's online. Judd can tell us.
my third comment, it's not a question, it's more of a comment. I hope you get funding for the TAC.
I know.
For the younger ages, because I think looking at those early infections is really interesting. And obviously you can do so much with the longitudinal data.
Yeah, I think that one thing that'll be really interesting in terms of those early infections and seeing if we can unlock some additional funding is the serology data. Because if we have serology at 6, 9, and 12 months, and so that can help us know like whether we're seeing, if we see some differences in the serology data at the different time points, and we'll have those data in like a couple months, hopefully if all goes well, and that I think could help us decide whether it's worthwhile to do that additional testing. Yeah. Any chance Jed answered the question in the chat about the
timeline?
Yeah, the timeline. I mean,
I think it was a week, but I don't want to say that. For visits.
Oh, for
like the 12-month visit, how close to 12 months it was?
I think it was more than a week.
More than a week?
Yeah.
Okay.
No answer. Okay, Jed or Matt, if you want to answer that question in the chat, feel free.
All right, congrats. I know, incredible amount of work. And I guess I'm curious with...
2-week buffer on the 12-month.
So you showed there was, you saw, think about causal chains, there's improvements in household connections, reductions in E. coli, potentially some impacts on some enteric pathogens. And I know you're not talking about Yarrow's work today, but then I'm kind of curious, like, are the pathogens that Yarrow's finding overlapping with the pathogens that you're finding reductions in children? Or, because it's like potentially, if there's no impact on Giardia, but she's not finding any Giardia in the piped water system, then logically it wouldn't be, those are exposures that are happening through food, soil, flies, or other pathways. I'm curious, maybe you haven't gotten there yet, but I'm curious what you guys are thinking about it.
Yeah, I would say that except for Cryptosporidium, which was kind of the most notable thing in her sampling, we haven't gotten there yet to look at it. We did do a quick look. I mean, we did do a quick look at the Cryptosporidium results to see, like, were they all found in the intervention in the comparison areas and not the control, and not in the intervention areas. That was not the case. So there's no easy, cool result there. But Yarrow's samples was very small numbers. I think it was like 50.
Well, more than that.
Twice.
Yeah.
In a rainy season and dry season. We did see some differences in rainy and dry season. But it's such a small number that we were able to do that large volume sampling on, that it's it might be a little specious even if we look at it. So, yeah.
I had a question about the parasitology results. Were those TAC? They weren't the microscopy results? Correct. Okay, because the numbers were really low, and not that I would expect the intervention to necessarily deal with the helmets, but do you know if there was a beak feeding step? Because those bad boys really need to be beaten up in the extraction, and so you might want to re-extract if you want to find.
Heidi can answer that question. She did the extractions.
So we would take the stool and then we would spike it and then we would BB in it, and then we would also centrifuge it before
we run it through, was it the CUBE and then TAC?
And it goes,
I will say the microscopy results, there was also a very low prevalence.
Okay.
Like
So they-
there was no
they're
major
points.
differences in overall prevalence.
Yeah, and also I think they were doing deworming.
Okay,
That's
that's
what we
And also, they're kids under 1.
Yeah.
These ones
yeah,
really peak
that's right,
later.
they're really low.
Yeah.
Yeah.
That's right.
Yeah.
Weeks to even get through the system. We got, yeah.
Oh, we over time?
No, we have like one more question.
Oh.
I was gonna say.
We have some questions for you all.
I was actually going to add, if not, I'll give everyone a second, but context to Drew's question about, because I think it's a really interesting thing to talk about, and you can show our discussion.
Okay.
Something I'm really interested in is like, when we think about the impact on, through the drinking water pathway of exposure to enteric pathogens through drinking water, but I think we'd be remiss not to mention that improved access to water could reduce exposure to enteric pathogens through other pathways. So we can't see that with our data, but improved hand hygiene, improved food hygiene, things like that can all lead to, so even if we don't see it, this traceable line linearly through this pathway, there could be other things. And I just wanted to add that comment, because
Yeah,
I think that's really interesting, particularly for this question, when we talk about, investing this much money in drinking water and not seeing, major health impact so far.
Yes, and there are the water sales. I think we should not underplay the sort of water satisfaction and the happiness of the people. Like, there's a lot of reasons to have a water system improvements, and so while we're focused on these health impacts, those are very important aspects as well. And yeah.
I was just gonna ask, related to that, did you collect water insecurity at one time point or multiple time
All of them.
points? All of them. I'd be curious to see if that also just changes over time.
Yeah.
The question was about water insecurity at one time point or many time points. Okay, I think we've run the clock, so thank you all so much for coming. Should we stop the recording?
Yeah, if you